Now I want to present the natural continuation of that project, the family physician's mind. If your family medicine companion was created to explain the lens of family medicine, then this notebook was created to train that lens, because understanding an approach is one thing. Practicing it repeatedly until it becomes a default skill is another. It is a clinical reasoning logbook, a rehearsal space where the resident takes the ideas from the companion and applies them to real patients, real symptoms, real diagnosis, real procedures, and real moments of reflection. The central idea is that with time, the mind should develop a disciplined sequence: safety, representation, differentiation, testing, and management. This sequence should run almost automatically whenever a patient sits in front of us. That is why the notebook is built around the 5-layer framework. First, safety: is the patient stable and what must not be missed? Second, representation: what is the problem in one clear clinical sentence? Third, differentiation: what are the major diagnostic buckets? Fourth, testing: what focused history, examination, and investigations will separate the possibilities? Fifth, management: how do we close the encounter using CRAPRIO, patient-centered care, prevention, follow-up, and safety netting? What makes this notebook different is that it does not give the resident a finished answer on every page. It gives the structure and asks the resident to do the thinking. And this is intentional. The goal is to build a mind that can reason. The first section represents the operating system of the notebook: the 5-layer approach, CRAP-REOP, ICE, motivational interviewing, stages of change, spikes, prevention, screening, and answer protection. This section reminds the resident that clinical excellence is not only about reaching the correct diagnosis. It is about thinking safely, speaking clearly, understanding the patient's perspective, managing uncertainty, preventing harm, and closing the consultation with a plan that can actually be followed. The second section is symptom-based clinical reasoning. This is extremely important because patients do not usually enter the clinic saying, "I have heart failure, I have pulmonary embolism, or I have inflammatory bowel disease." They come with shortness of breath, cough, chest pain, palpitations, dizziness, syncope, headache, fever, abdominal pain, unintentional weight loss, fatigue, back pain, polyuria, or polydipsia. Each symptom page forces the resident to start the way real family medicine starts. With an undifferentiated presentation. The page does not allow jumping to one diagnosis. It trains the resident to pause, assess danger, write one-line problem representation, build differential buckets, choose focused question and examination finding, then create a safe plan. The third section is the disease master pages. Here, the notebook moves from symptoms to confirmed or suspected conditions across the major areas of family medicine: urology, cardiovascular, respiratory medicine, endocrinology, renal disease, genitourinary problems, musculoskeletal and rheumatologic diseases, gastroenterology, women's health, mental health, pediatrics, and geriatrics. But even here, the format remains the same. Every disease is approached through safety, problem definition, differential buckets, hypothesis testing, CRAP-REOP, prevention, patient-centered counseling, follow-up, and examiner-winning phrases. This repetition is not decoration. It is a training. It teaches the resident whether the case is diabetes, hypertension, asthma, stroke, depression, dementia, antenatal care, or frailty, the family physician's structure remains steady. The fourth section is the procedural logbook. This part recognizes that procedural competence is not simply about performing a technical step. A safe procedure begins with indication, contraindication, equipment, consent, preparation, technique, complications, aftercare, documentation, and supervised competence. The notebook includes procedures such as pap smear, high vaginal swab, IUD insertion and removal, implant insertions, suturing, abscess incision and drainage, ECG placement, neonatal examination, joint aspiration, spirometry, foreign body removal, and sebaceous cyst excision. Each procedure becomes more than a checklist. It becomes a supervised learning encounter where the resident can document growth and identify what still needs a practice. The fifth section is the clinical reflection journal. Many residents see hundreds of patients, but not every patient automatically teaches us unless we pause and extract the lesson. The reflection pages ask the resident to write the patient summary, the one-line problem representation, the leading diagnosis and why, what almost fooled them, what guideline mattered, what the patient believed, what the patient feared, how ICE or CRAP-PEOP was used, what could be done differently, and finally, one active recall sentence for future board review. This is how clinical experience becomes clinical growth. The notebook also includes worked examples, such as newly diagnosed type 2 DM patient, new type 1 diabetes and TKA, newly diagnosed hypertension, and uncontrolled diabetes requiring escalation. These examples show what a complete 5-layer approach looks like when fully applied. Then, after seeing the model, the resident is asked to continue the work on blank templates with their own patients. So the relationship between the two projects is very clear. The companion says, this is how family medicine thinks. The notebook says, how now let's apply it, patient after patient, until it becomes instinct. This is why I see this notebook as a logbook. But not only a logbook in the administrative sense, it is a logbook of thinking. It records not only what the resident saw, but now the resident, how the resident reasoned, how they communicated, how they planned follow-up, how they protected the patient, and how they improved after the encounter. Its purpose is to move the resident from passive studying into deliberative practice. Before clinic, it can be used to rehearse the structure. During clinic, it can organize the encounter. After clinic, it can turn the case into reflection and active recall. Over time, the repeated use of the same framework should create something deeper than a filled notebook. It should create a trained clinical mind. This is why the family physician's mind is not simply an appendix to the companion. It is the practical training ground for it. It takes the philosophy of family medicine and turns it into daily exercise. It takes clinical reasoning and turns it into a habit. It takes residency encounters and turns them into a record of growth. If the companion is the map, this notebook is the road walked every day. And my hope is that a resident who uses it seriously will not only finish with organized pages, but with something far more valuable, a safer, clearer, more patient-centered, and more confident family physician's mind. This framework is informed by established clinical reasoning concepts, including problem representation, illness scripts, diagnostic comparison, safety first assessment, patient-centered consultation models, and family medicine management planning. Its contribution is the integration of these concepts into a structured, teachable approach for family medicine residents.